This video will explore the background, etiology, pathophysiology, epidemiology, clinical features, investigations, management, complications, and prognosis of lung cancer. Lung cancer is the third most common malignancy in the UK and is the leading cause of cancer-related deaths. There are around 48,000 cases of lung cancer diagnosed in the UK every year. The overall survival in the UK is 41% at 1 year and 16% at 5 years. The prognosis depends on the age and the stage at the time of diagnosis. Smoking is the cause of 80 to 90% of lung cancer cases. The relative risk, even after smoking cessation, remains at twice that of a non-smoker at 30 years after cessation. Other risk factors include asbestos exposure. This has been linked to mesothelioma, but also adenocarcinoma, pollution, idiopathic pulmonary fibrosis, family history, and radon exposure. There are several subtypes of lung cancer. Firstly, these can be divided into small cell, accounting for 15% of cases, or non-small cell, accounting for the remainder. Small cell lung cancer has a central location in the chest and is derived from neuroendocrine cells of Kolchitsky. It has a strong association with smoking and unfortunately is often aggressive and metastasizes early. On histology, it can be identified by small round blue cells which are poorly differentiated. Non-small cell lung cancer can be divided into several other subtypes: squamous cell carcinomas, adenocarcinoma, large cell carcinoma, and carcinoid tumors. Of these, squamous cells are usually centrally located, and adenocarcinomas are usually peripherally located. Squamous cell carcinoma can be identified by keratin pearls on histology. It is also strongly linked to smoking. Conversely to small cell lung cancer, it tends to metastasize later. Adenocarcinomas can be identified histologically by glands or mucin on histology. Though smoking is also a risk factor, it appears proportionally higher in non-smokers. Large cell lung cancer appears as poorly differentiated on histology. This subtype tends to metastasize earlier. Finally, the carcinoid subtype is seen as small round blue cells and is well differentiated on histology. Clinical features for lung cancer include chest pain, hemoptysis, a persistent cough, and dyspnea. There can also be a hoarse voice if recurrent laryngeal nerve compression occurs, for example in a Pancoast tumor, which is seen at the lung apex. It can also present with non-specific symptoms such as unintentional weight loss, malaise, fatigue, and night sweats. However, it can frequently be asymptomatic. Several signs can be seen in lung cancer. These include clubbing, tar staining if the patient's a smoker, lymphadenopathy, and chest signs, for example, wheeze and dullness on percussion. Other signs and symptoms can be seen if paraneoplastic syndromes are present, for example, abdominal striae in Cushing's syndrome, seen in small cell cancers, or finger clubbing and joint swelling, seen in hypertrophic pulmonary osteoarthropathy, which is seen in squamous cell cancers. Paraneoplastic syndromes will be discussed in more detail in a subsequent video. If complications have developed due to tumor overgrowth, then further signs may be seen. A large central tumor may compress the esophagus and cause difficulty swallowing, known as dysphagia. If superior-vena cava obstruction has occurred, then the patient may have distended neck and facial vessels and chest edema. If Horner's syndrome has developed, for example, due to a Pancoast tumor at the lung apex, this can present with miosis, a constricted pupil, anhidrosis, loss of sweating on the affected side of the face, and ptosis, which is eyelid drooping. Bedside investigations for lung cancer include general observations and lung function tests. Blood tests should be performed including a full blood count, urea and electrolytes, bone profile, and liver function tests. Imaging should be done, and a chest X-ray can show a coin-shaped lesion. However, lung cancer should also be a differential diagnosis in lobar collapse and pleural effusion seen on a chest X-ray. For further staging and to assess distant spread, a CT chest, abdomen, and pelvis, or a PET-CT may be done. Biopsy approach depends on the type of tumour. If it is peripherally located, then a percutaneous biopsy is usually done. If the tumour is central, then an endobronchial biopsy approach is taken. Cytology analysis may be done from aspirates, washings, or pleural fluid. Spirometry may also be done to assess patient fitness prior to surgery. A 2-week referral for suspected lung cancer should be done if there are chest X-ray findings that suggest lung cancer, or if the patient is over 40 years of age and has unexplained hemoptysis. An urgent chest X-ray, performed within 2 weeks, should be considered if the patient is over 40 years old and has persistent or recurrent chest infections, clubbing, supraclavicular lymphadenopathy, chest signs that are indicative of lung cancer, or thrombocytosis. If the patient is over 40 years old and they have 2 or more of the following signs, or if they have 1 or more of the following signs and are a smoker, then they should also be considered for a 2-week urgent chest X-ray. These signs include cough, fatigue, dyspnea, chest pain, weight loss, and appetite loss. Management of non-small cell lung cancer depends on whether the disease is metastatic or non-metastatic. For non-metastatic disease, stage 1 to 3A, management is usually curative surgery. This can include lobectomy or pneumonectomy, plus or minus chemotherapy. Lobectomy is where 1 or more of the lobes of the lung are removed, and this is done if the cancer is localized to just 1 lobe. Pneumonectomy is when an entire lung is removed, for example, if the cancer has spread throughout the lung. An alternative is wedge resection or segmentectomy, where a small piece of lung is removed. This is usually only done for very early stage non-small cell lung cancer. An alternative treatment approach is using curative radical radiotherapy. For metastatic disease, stage 3B+, then palliative immunotherapy, chemotherapy, or radiotherapy is often given. The immunotherapy drug pembrolizumab stimulates the immune system to target and kill cancer cells, and it may be given on its own or combined with chemotherapy. It can be used in non-small cell lung cancer. Management of small cell lung cancer depends on whether the disease is limited or extensive. In limited disease, it's usually treated with chemoradiotherapy, with platinum-based agents such as cisplatin. Surgery may be done for early stage disease. For extensive disease, chemoradiotherapy is also done. Lung cancer can commonly metastasize to other regions. These include lymph nodes, which can cause lymphadenopathy, bones, causing bone pain, contralateral lung, brain, adrenal gland, or liver.